Welcome to our webinar today that is about building community trust to improve COVID-19 vaccine confidence. Today we have four very distinguished social scientists who are going to discuss the context of community trust and mistrust and draw on some of the lessons that we have learned about vaccine deployment from the past. The aim of our webinar is to discuss operational strategies and recommendations for COVID-19 vaccine rollout. And this includes how to build a more culturally and ethically responsive but contextually informed community engagement approach. So I will begin by giving you some information about the agenda of our program, which you can also find in the chat. But for the meantime, this webinar is being hosted by the COVID-19 Clinical Research Coalition. This is a global coalition that has got 13 different working groups, and for today we are in the social science working group of that clinical research coalition. The coalition was formed in 2020 April by clinical researchers and scientists to respond to a growing concern about the impact of COVID-19 on some of the low income settings. Particularly, they had certain priorities, research priorities they felt within the low resource settings that were not being adequately supported. So we seek as a coalition to leverage some of the global expertise of some high impact research, while also championing equitable and affordable access to vaccines, diagnostics, treatments. But very importantly, we also promote open sharing of research knowledge. So at this point, if you're interested in joining this coalition, please join us. You can find our link in the chat right now. Or a little after. So for today, I would like to tell you a little bit about the social science working group. The social science working group was put together very early on in the pandemic because we wanted to highlight some of those social science issues related to clinical research in low and middle income countries. We have so far had a lot of achievements, exchanged a lot of experiences, lessons learned through conducting social science research on COVID, including realizing that it is important to focus on the political and economic structures that shape the pandemic or its response. Understanding how social scientists can contribute to community engagement. These sets of priorities have now been published in the BMJ Global Health, an article that you can also find now in the chat. It gives more details of our priorities as a social science working group. We have managed to conduct advocacy on this issue of vaccine equity, particularly advocating for TRIPS waiver to enable fairer access to COVID-19 vaccine technologies. The working group is co-chaired by Professor Shelley Lees in the London School of Hygiene and Tropical Medicine, and myself. And the current members are listed there on the slide. But we welcome you to find more information about our working group on the coalition website. Again, you can check in the post right now. So I, David Kawamafijiri, is your host today. and I am a social scientist, medical anthropologist based out of Makerere University. And it's a pleasure to host you here. We are going to have our agenda, as you can see there, 4 very distinguished social science experts to speak to us today. And before they do that, the agenda generally is they'll speak for 10 minutes each, and then we have about 20 minutes to discuss. But let me give a few housekeeping tips before we start the webinar. First of all, I want to alert you that we are recording this webinar, and that link will be available for those who may not attend or break off or for want to revisit. So you will find that link also in your emails. Secondly, we have a Q&A tool, question and answer tool. Please use that tool. It will be at the bottom of your screen, and you can use it to ask your questions as you're listening to the presenters. Very interestingly, the tool allows you to upvote and increase on ranking of which questions will be answered first. So if you find a question you really like, you can like it, upvote it. So do not use the chat for the questions. Please use the Q&A tool. But if you can address a specific question to a specific presenter, that would be really, really helpful to the presentations. We will then open up the chat a little later during the discussion and also during the Q&A session. So at that time, interact with anyone, including yourselves, and we shall keep answering some of your questions. Lastly, we will have a short survey at the end of the webinar that we encourage you to please fill out. You will have a short survey, and we encourage you to please fill it out. Now, we will have a poll question that we may want to introduce. Just before I introduce the first speaker, we request you to please answer that poll on your screen right now. We just need to know a little bit more about you. That would be so wonderful. I assure you the poll is completely anonymous, and we will be giving you those responses, the outcomes, the findings or results, right, at the earliest convenience. Fantastic. So now I would like to take the opportunity to introduce our first speaker. So you can see our poll there is coming up in the agenda, who is Svea, Professor Svea Closer, is a social scientist based at the Johns Hopkins School of Public Health, Bloomberg School of Public Health. And Professor Svea is a medical anthropologist and an associate professor of international health who uses a lot of ethnographic research methods, very interestingly, to study the complexities of public health policymaking and implementation. More relevantly for us, she has now been involved in research both in Pakistan on polio vaccination and in Ethiopia. I will refer you to our chat later where we'll post some of her most recent works, or you can search on them. But a seminal one that we all are aware of is a book on chasing polio in Pakistan. Professor Svea, you are welcome.
Thank you so much. I really appreciate the welcome, and thank you, everyone. I'm really looking forward to the conversation with all of you around these really important topics. So today, I'm going to talk about the polio program, the Global Polio Eradication Initiative, because it has a lot of lessons about trust in vaccination programs. And there are some great takeaways about how to build trust, but also how to lose it. Those are my themes today: how to build trust, how to lose it, and then a little bit about how not to lose it. Along with colleagues across the world, I've been studying the polio program since about 2005. And today I'm going to be drawing from 3 different Gates-funded research projects spanning 11 countries in sub-Saharan Africa and South Asia over the past 10 years. And I'm going to do it all in 10 minutes. So here we go. For those of you who may not be aware, the polio program is a $12 billion project that's employed an estimated 200 million workers to deliver 20 billion doses, billion with a B, of oral polio vaccine in campaigns across the globe. And these campaigns are often door to door. So as an historic project that's currently serves as a major model for global health action, it has a lot of lessons that have relevance for a broad range of public health programs, including, for our purposes today, COVID vaccination. So first, I want to talk a little bit about some of the things the program has done to build trust. And these strategies won't be a surprise to most of you. So the polio program has a pretty extensive communication strategy. It's very sophisticated. Many of you have probably seen it in action. And the goal in that communication strategy is to really work across the social ecological levels, all the way from high-level policymakers down to individual parents, and to have tailored communication strategies for different groups in all of those levels. So for example, the program engages politicians, like the Nigerian politicians on the left here. It engages movie stars. Many of you are likely familiar with the 2 men on the right as advocates for the polio program and for polio vaccination. Then at the local levels, the polio program also works with local community groups and does, in some cases, door-to-door messaging by women in a given community, providing messages to mothers of young children. So young children are the population that's being targeted with polio vaccine in this case. So this is the standard polio playbook. It worked in most places and most times, and the strategies won't be a surprise to most of you. But sometimes it didn't work, and there's a lot to be learned from those examples. So that's where I want to take us next. So part 2 of my 10 minutes is how to lose trust, some lessons from the polio program there. And I'm going to focus particularly on Pakistan and Afghanistan, where there was little or no resistance to the polio vaccine in the mid-2000s, and then significant resistance in specific communities now. And this all happened as these communication strategies were ongoing. So what happened here? There's some real lessons for COVID control, and there's resonances with it, not just in Pakistan and Afghanistan. You also see some of these same dynamics in Nigeria and some other areas in sub-Saharan Africa as well. So historically, there's been an emphasis on campaigns in the polio program, and to some degree, a de-emphasis on routine immunization at the global level. And this was due to concern over diluted priorities. People felt that the need for eradicating polio was great, and the single disease focus would be the most efficient way to achieve that. And you see that in the COVID, in conversations around COVID now too, of course. At the operational level, this means that polio staff going door to door in many countries across the world often heard people's complaints, concerns, requests about health services, but were only able to provide them with one vaccine. So currently, the last of the world's communities affected by polio are socially, politically, and economically marginalized. Most of them experience some combination of conflict, migration, environmental hazards, poor transport networks, flooding, and government persecution. So repeated doorstep visits by polio workers in these marginalized communities over decades eventually led to refusals and resistance. And I want to point out something really important here. This didn't happen right away. It was something that got built up over time. So over time, the polio program came to be seen in some of these communities as emblematic of government and international agencies' lack of understanding of some of their most pressing problems. In Nigeria, a respondent said, quote, "People want food, and they're saying we're committing a huge quantity of resources to address a disease that's hardly ravaging anybody." In Pakistan, a worker said, quote, "People say, why don't you people give us sugar and flour at our doorstep? Why only vaccines? These are also needs, and people can die because of these things as well. A child can die because of hunger." And this was particularly acute because of the intensity of polio vaccination activities. In many polio endemic areas, there may be a campaign 10 times a year. So in Afghanistan, a respondent said, quote, "Now the community is tired of vaccination and they want a change in the program. They request other things such as clean drinking water, access to other health services." And respondents in Nigeria had similar comments. And these issues were particularly acute because the polio program was relatively well-resourced, well-run. So in some ways, the polio program had done everything it could to build trust. It had high-quality services delivered right to people's doors. The issue was that the other health services that these communities had were not at that level of quality, and in some cases, they were non-existent. So for example, a respondent in Pakistan said, "People demand basic facilities, education, health, sanitation. It's unfortunate that in our dispensary, we don't have everyday medicines. We don't have a female doctor." So it's that mismatch between the quality of vaccination campaigns and the quality of health services generally that was a catalyst for mistrust. One particularly striking example of this is something called demand refusals, which is where communities would organize to refuse polio vaccination as a group en masse in an attempt to gain attention and recognition for some other services that they really needed. And often when you speak to these communities about this, they'll say, "Look, we know that the polio vaccine works. We know that polio is an issue, but we feel like we have no other way to get people to listen to what we're trying to say about what we really need." So in these contexts, that traditional communications playbook of repeating polio messaging at all these different levels can actually make things worse because it can highlight the disparity between the focus on this one disease and perhaps lack of attention on other health issues. So the takeaway here is that just focusing on one disease can actually be counterproductive for the vertical program itself, but that this might not become apparent right away. Like this, these issues and the trust that sort of can erode in these situations manifest over time. And it's not to say that people didn't appreciate the polio vaccination. Mostly people did, but they were frustrated over prioritization. So finally, I'm going to talk about how not to lose trust. The polio program has some great examples here too. So the theme across all of these things I'm about to talk about is that if health systems in an area are not strong, it's best not to bypass them with just one vaccine. So then what do you do instead? Here are some strategies. The first is to provide other health interventions along with COVID vaccination. So an example from the polio program in Nigeria is really interesting here. In the mid-2000s, Nigeria added a number of other interventions to its polio campaigns, including vitamin A, other vaccines, antihelminthics, oral rehydration salts, and treated bed nets, soap, other things like that. In addition, COVID vaccination can be used as a way to monitor and then deliver additional health services. So an example here is from India, where migratory populations, when polio teams went to their doorstep, they also used that as an opportunity to identify other needs in the community and then deliver those needs later with mobile vans. Another thing that's really important is to provide communication messages that go beyond vaccination. Here's another example from India, where the polio program didn't just message about polio in the last phases. They actually included a suite of messages about breastfeeding, routine immunization, and oral rehydration solution. And that went over much better in marginalized communities. And finally, we need to think about supporting health systems for the long term. In the words of one respondent we talked to in India, it has to be polio plus, 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 plus. So I'd suggest that to build trust, it will have to be COVID plus, 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 plus as well. So I want to thank my partners in many countries so much. I didn't have time to thank them all here by name, but they know who they are, and I'm very, very indebted to them. So looking forward to the conversation.
Thank you very much, Professor Closer, for keeping in time. Next, we have Professor Fong Ming Moy from the University of Malaya in Malaysia. Professor Ming is an epidemiologist in the Department of Social and Preventive Medicine, who studies promotion of awareness on non-pharmaceutical intervention measures and vaccination, particularly during this pandemic. Professor Moy, please, you're welcome. Thank you.
Thank you, David, for the kind introduction. First, I would like to thank the organizer for giving me the opportunity to share our country's experience in building the people's trust in making the national vaccination program a success. Okay, first I would like to introduce where I come from. Malaysia is made up of Peninsular Malaysia and the East Malaysia in Southeast Asia. And it is a multi-ethnic and multicultural country with a population of 32.7 million. It's made up of almost 70% by the Bumiputra, means the son of the land, which who are ethnically Malays and indigenous people, with 22% Chinese, about 6-7% Indians and others. So our official language is Malay language, but English is the active second language. Islam is the country's established religion, but the constitution grants freedom of religion to non-Muslim. As vaccination is one of the most effective measures in combating the COVID-19 pandemic, similar with other countries globally, Malaysia has pushed for it aggressively in order to bring the country out of the lockdown. So our country's COVID vaccination program started on the 24th of February 2021, which is divided into 3 phases, with the first phase for the frontliners, the healthcare workers, phase 2 for the older person and high-risk individuals with comorbidities, and last phase for all remaining adults. That was before vaccines were considered safe for adolescents. So in my presentation, I'm going to share with you who are those people having vaccine hesitancy, and what are the reasons, and what did we do, and whether they are convinced. So those people involve the older persons, the adults with comorbidities, or individuals with uphold strongly to their cultural or religious background, and individuals who stay in remote areas which they may not have access, and so on. So these are some of the reasons that our people were rather hesitant for the COVID-19 vaccine. The main reason being they have inadequate information on the benefits and side effects of the vaccines, and they worry that the vaccines will bring harm to them, and so on. Cultural and religious reasons are also important, that they felt that the Muslim felt that the vaccine may not be halal, which is prohibited from the view of the Islamic law. And some also felt that if they get the disease, they get infected, it's fated, and they leave it to God. There are also some elements of distrust of the government, as well as some vaccine conspiracy theories. There was also a survey done among the low-income families living in public housing. About 1/3 of them were unwilling to be vaccinated despite being offered free vaccines. They were worried about safety and side effects. So this shows that they were not informed. That's why they have this concern. Other important factors for vaccination were whether the vaccine is convenient for them to take it, and doctors' recommendations were also important factors for vaccination. I would like to present a little bit about the situation of COVID-19 in my country. So in March 2020, when the pandemic started, the cases in our country were actually quite low until end of 2020, where there was a state election. So immobility was increased, and then there was a spike. And then sometime in July, there was a sharp increase. And now with the vaccination rollout, our cases has come down. So similarly, you see the same trend for death or mortality. So why is this sharp increase? Is actually due to the Delta variant, all right? So up to date, we have cumulatively more than 2 million cases and 27 over 1,000 deaths. So the situation that I just showed has served as a wake-up call for our people, and concurrently, the government has taken a lot of measures such as providing timely and accurate information about benefits of vaccination, addressing fake news, misinformation which are being circulated in the social media, was more transparent on the side effect of vaccination. So for those vulnerable groups, we had outreach programs such as the indigenous population who stay remotely far, and those bedridden, homebound, and so on. And for convenience and to fasten the rates of vaccination, we also set up mega vaccination centers and engage general practitioners in the community to make it more convenient for the people. And initially, the vaccination required registration, but later the government was more flexible that they allowed walk-ins for older person, individuals with comorbidities, and it is also free for foreigners. So for documented foreigners, there was no problem, but for the undocumented foreigners, undocumented workers, there were a fear of being taken action by the police. So what happened was the government actually engaged the NGOs that used to work with them and the community leaders, as well as the embassy's representatives, to give them the confidence to come forward for vaccination. So if you look at the chart here, there was a survey done on our people's willingness to be vaccinated. So initially in December 2020, it was only around 64%. And now up to the latest August 2021, 95% of them reported to be willing to be vaccinated. And this is shown in our vaccination rates in Malaysia. So if you see over the right side here, actually we have almost 65% of our total population fully vaccinated, with 75% with at least one dose. So among the adults 18 years and above, only we have 5.3% unvaccinated. And we have started vaccination for the adolescents in middle of September, and it is going on very well. Okay, so what are the reasons of this 5% of adults who are not vaccinated? So this will be a very, the task will be very challenging to convert them. And so I think currently the government has some carrot and stick policy where those unvaccinated are not allowed to dine in, are not allowed to travel interstate. So probably this may convert a small proportion of these 5% adults to be vaccinated. However, we should find out what are the reasons, what are their reasons for refusing vaccine, and we should try to convince them. So this will be a challenge for all of us. Thank you.
Oh, Great. Are you done? Oh,
Yes, yes, thank you. That's all for my
fantastic.
presentation.
Fantastic. Thank you very much. Again, also for keeping within time. This is fantastic. That's when you know you are listening, professors. So our next speaker will be Dr. Sarah Cooper from Cochrane, South Africa, with the South African Medical Research Council. And Dr. Cooper has conducted a lot of work with the University of Cape Town, including in areas of health research, health policy, and practice, including areas such as long-term chronic illnesses, including mental illness, diabetes, but will give us very interesting insights because of her background with vaccination research and emerging methodologies of qualitative evidence synthesis. Dr. Cooper, you are welcome. Over to you.
Thank you very much, David, and for the warm welcome, and thanks for having me here. So over the last 3 years or so, myself and colleagues have been undertaking a Cochrane review of qualitative evidence synthesis on parents' acceptance of childhood vaccines. And so my presentation today is really going to focus on some of the relevant findings from this review. While the focus was on parents and on routine childhood vaccination, I think there are many lessons that can be drawn on for building community trust for COVID-19 vaccines. Oops, sorry. Okay, so the objectives of our review were firstly to synthesize the findings from qualitative studies exploring parents and informal caregivers' views and practices regarding routine childhood vaccination, and then secondly, to develop a conceptual understanding of the dynamics and contributors to reduced parental acceptance of routine childhood vaccination. Our analysis included a total of 27 qualitative studies, including from Africa, the Americas, Southeast Asia, Europe, and the Western Pacific, and also included urban and rural settings, as well as high, middle, and low income settings. So one of the major themes that emerged was the role of a lack or a breakdown of trust in the institutions or systems implicated with vaccination. And we found that the reasons for this distrust were incredibly varied and complex, but could be usefully divided into kind of 4 main contributors. So I'm very briefly going to go through each of these contributors. So a first major contributor, which really emerged from studies conducted in the geopolitical north, was what can be understood as a kind of more generalized decline in trust. So these studies really showed how increasing skepticism and doubt about science, of expert knowledge, and of other authorities is really a pervasive feature of social life in many contemporary industrialized societies. And so vaccine hesitancy for some parents was really part and parcel of this larger trend. So as captured by a parent from one study in Britain, they said, intrinsically, we don't trust them, government. Whoever they are, whatever party, there's always a suspicion. A second major contributor that emerged from studies, also predominantly from the geopolitical north, was concerns about the agendas or interests embedded in vaccination systems. And many parents here were particularly concerned about the economic interests of these systems, and especially here, the economic interests of the pharmaceutical industry. So numerous parents perceived the commercial interests of pharmaceutical companies really to be tainting vaccination systems. And this included biasing the systems of research, the intentions of health professionals, and the procedures of government. As one parent from a study in Canada explained, some of the reasons for my reticence towards vaccination come from the fact that vaccines are produced by drug companies that have, yes, interest in health, but above all, commercial interests. A third contributor to a lack or breakdown in trust, which emerged in studies from diverse settings and population groups, was the role of particular scandals or controversies related to vaccination specifically, or health-related issues more broadly. So the occurrence of these kind of scandals and the manner in which they were perceived to have been handled caused some parents to feel misled by authorities, and really in turn to question their legitimacy in protecting the public's health. So there were many examples of these kind of controversies or scandals. One example comes from a number of studies that were conducted in Nigeria, which highlighted the role of the controversial Trovan clinical drug trial in the 1990s, as well as the state boycott of the polio vaccine in the 2000s. So these studies found that even though these incidents occurred over 2 decades ago, many parents still attributed their suspicion of vaccination to these historical incidents. And for them, these controversies really served as evidence that both Western pharmaceutical companies and local government just can't be trusted. Another pertinent example of the role of health scandals that emerged from the studies is the family planning program of the 1970s in India. So various studies in India found that Muslims believed that they were specifically targeted for sterilization during this family program. And they believed that polio vaccination was just a continuation of this agenda. So as one Muslim parent said, before this, they had forced sterilization. Now the government is doing this through polio program. That same program, the family planning program, is repeating in another guise. Importantly, what many of the studies revealed is that these health-related controversies and how they are interpreted and then impact on vaccination views really don't take place in a vacuum. Rather, they occur within particular political contexts and historical moments, and are therefore also shaped by these. So, for example, the studies in Nigeria really revealed how perceptions of the Trovan trial and the polio vaccine boycott and the impact they had on vaccination views were deeply entangled with a long and painful history of medical colonialism in Nigeria, of North-South religious and political tensions, as well as more recent kind of post-colonial inequalities and top-down global public health initiatives. So in other words, health-related controversies and their impact on distrust of vaccination can really only be properly understood if placed within the kind of wider political and historical context in which they occur. And then the fourth and final contributor to distrust emerging from the studies, also in diverse settings, is captured by the concept of social exclusion. And here, a lot of the stuff that Svea was talking about really we found in many studies. So social exclusion may entail various different dimensions: poverty and inequality, residential segregation, a lack of political representation or power, discrimination, unequal protection of rights, and many, many other dimensions. And what emerged in various studies is how all these different dimensions of social exclusion may lead parents to be less accepting of vaccination through varying mechanisms of effect. So, for example, experiences of social exclusion may rupture state-citizen relations, and this in turn may lead excluded communities to lose confidence that those in power have their best interests at heart. And they may become increasingly skeptical of initiatives supposedly offered for their benefit when they are disadvantaged in so many other aspects of their lives. So as one parent in a study from Nigeria said, "We are looking for medicine in the hospital to give to our children, and we can't get it. But this one, the polio vaccine, they are following us to our houses to give it. I don't trust this polio vaccine." Experience of social exclusion may also generate a climate of alienation from and anger towards authorities. For example, many marginalized parents in the studies expressed resentment at being asked to take part in vaccination programs when what they considered to be their principal concerns were being neglected. As one parent from India said, we have malaria here. We are in so much misery. The children have diarrhea, and you are forcing them to take this vaccine. If the child is sick, make the child better first. But the study showed that in such cases, vaccination may be rejected by some parents as a form of resistance against authorities. And again, Sphere really showed us that as well. And in some cases, it can even become resistance a bargaining tool for communities to have their principal concerns and priorities addressed. And so while this might seem counterproductive to us, it's arguably a really strategic and potentially desperate response to oppressive contexts where lives and livelihoods are fundamentally threatened. So in conclusion, what are some of the take-home lessons I think we can take from this, from the findings from our review? So firstly, I think the reasons for distrust of vaccines and vaccination programs are really complex and contextually situated, embedded really in the intricacies of particular political events, relations, and processes within very specific times and places. And so I think, as one of the studies really argued, we need to move away from this kind of shorthand universalizing qualities of the concept of distrust to understanding and then responding to why trusting relations between communities and institutions in all their kind of rich diversity and texture might have broken down. I think so often the concept of distrust has become a kind of catch-all phrase, a sort of easy explanator that appears to say everything, but also nothing. And I think at the same time can deter sort of more specific and perhaps awkward questions about interests and power and relations. And then finally, among strategies to build trust, I think there's frequently, the focus is always on the kind of mistrustful individuals and communities. Yet I think what our reviews also really showed is there needs to be a focus on almost a kind of also shift in lens onto us, the experts, the institutions or systems, and the structural conditions that contribute to the kind of rupturing of community distrust, of community trust. Thank you very much.
Thank you. Thank you very much, Sarah, for that wonderful presentation. You listed some of your publications from the Cochrane synthesis. So if it's possible to just put them in the chat, that will also be helpful for us to pick them there or in the Q&A. So as social scientists, we obviously are very sensitive to diversity. So let's balance gender. I want to now have Anthony Mansari, who is based at the London School of Hygiene and Tropical Medicine, but I think today will be coming to us from Sierra Leone. Anthony has got several affiliations, but most importantly is engaged in predominantly public health research in issues surrounding governance, emergency response, and currently now leads the social science research on the Ebola vaccine and Prevac Ebola vaccine trials based out of northwestern Sierra Leone in Cambia. Anthony, you are welcome, sir. Thank you.
Thank you very much, David. Really, really appreciate that warm welcome. And hello, everyone. My presentation this afternoon is titled Reclamation of Community Trust, Exploring Engagement with Vaccines from Ebola to COVID-19 in Sierra Leone. I'll want to share findings from some of the recent work we have been doing in epidemic preparedness and building community trust and vaccine confidence from some of the most recent work we've been doing around the Ebola vaccine trials in Sierra Leone. But before that, I'll give you a little bit of context within which all of this work is being done. So Sierra Leone, as most of you will know, has a long history of political instability characterized by corruption, marginalization, regionalism, and other forms of social injustice, which mostly leads to, or some of the precipitators or enablers of distrust in community, leading to a decade-long civil war and a failure of the state, or what you will call an erosion of trust, or an erosion of the state itself and its functions. So this had tremendous impact on health systems with a long history of poor immunization coverage, having long demand and supply side problems, issues with community acceptability, and lack of trust in public health interventions. So you can imagine that within this kind of context, it could be very hard to instill trust, but also very hard to have uptake of public health interventions in general. Fast track to the Ebola outbreak in Sierra Leone. Responses mostly focused on the role of scientific and epidemiological models in responding to outbreaks of such nature. It failed to take into consideration cultural and traditional practices, such as burial practices, the idea of isolation of sick persons, traditional healers, and as alternative health-seeking behavior, which of course contradicted some of the scientific ways of infection prevention and control. Our response strategies in the earlier stages of the Ebola outbreak focused more on how scientific modeling and epidemiological modeling can tackle the spread of Ebola. And of course, we saw how it spread quite fastly within the sub-region, like a wildfire in the Hamatan bush, as I will call it. But then later on in the response, we realized that there is a need to bring back those core traditional values, because people felt like the only thing that they held on to, this being a trial or a very big challenge to their community and core values, the only thing things they can hold on to were those cultural and traditional and religious beliefs that they held on to. So we started new approaches of community engagement, talking to or engaging community leaders such as religious leaders, traditional birth attendants, local mobilizers, and trying to reclaim trust and build community-led actions that actually incorporated some of those community values and ensured that in as much as we want to ensure IPC measures, we also adapt to some of the community needs in the outbreak response. Learning from these measures during the outbreak, when the London School and other local partners started the Ebola vaccine trials at the end of the epidemic, at the end of the outbreak, we realized that there was a need for us to have a social science component within the clinical trials. And some of the work we've been doing have been trying to understand the cultural and social dynamics around vaccine trials, but also be able to build trust and vaccine confidence and community-led responses in preparedness and epidemic response. So I'll give you some quick findings from two key research we've done recently, just to understand what communities prefer. One, in areas of vaccine deployment, and also what are the practical solutions that can adapt to community needs, but also increase confidence in vaccine deployment at community level. It was interesting to see that most community members found it quite useful to have community representatives as part of vaccine deployment teams or vaccination teams, just to enable trust and confidence in the process itself. Many communities believe that having community leaders taking the lead in taking vaccines will serve as a good example to the rest of the citizenry or the rest of the population in taking vaccines. What really fascinated me about this work was also the idea of people taking one vaccine strategy versus another, say a pop-up strategy versus a ring vaccination, or a single dose versus a multiple dose. We found out that communities were able to dissect and understand some of these different approaches and try to see how their context can actually fit within these complex epidemiological models, and making sure that it's adaptive and kind of responds to their needs as well. More recently also, we conducted a community, we conducted a research on vaccine confidence in few communities in Freetown, trying to understand people's thoughts on vaccines and what they think trying to understand thoughts around vaccine confidence and what could best work for them. And in these findings, we realized were that people were more likely to take vaccines if they saw that there is confidence in government's response. That was the first thing. We also realized that people were more likely to take vaccines if they had more messages about the side effects and if more community engagement was done. At the time of this research, we also realized that 60% were more willing to take vaccines if in one way or another their trust in government was affirmative, if they were able to say that, oh, our trust in government has increased over this period or has decreased over this period. So we saw that trust correlates a lot with confidence in taking vaccine, but more importantly, also information at the community level was quite important for people to understand like these different dynamics in building trust. So some few recommendations we came out with at the time was to have intensification of community engagement and open dialogue to build trust in COVID-19. So talk about the dangers of vaccines and rumors and concerns. And also another key thing we recommended was to capitalize on drivers of vaccine confidence, that continuously monitor these drivers which change over time and among different localities and groups. Trust in COVID-19 response as a whole matters for vaccine confidence, and vaccine confidence efforts must aim to build trust. Global advocacy for fair access to vaccine we saw was also something that needs to come out strongly at national level and at global level as well. Some final thoughts as I close down. Vaccine delivery can align with population needs and thus boost vaccine confidence. If we can make it adaptive and continuously monitor those perspectives and experiences at the community level and thoroughly address them, it gives a perfect opportunity for communities to be engaged in not just seeing themselves as individuals who are on the receiving end, but as individuals who can also form part of the process of fighting a much bigger fight than just themselves. Thank you very much.
Thank you very much, Anthony, for your presentation. We have a few more minutes to have our question and answer session. So I'll go right into it. As you've seen, we've had quite a diverse group of presenters, and so I want to trust that we shall handle all the questions coming in. Please keep those questions coming. If we don't complete them, we will be able to keep interacting. So first of all, I think one of the most interesting issues going on is the challenges. People are noticing there are lots of challenges as we conduct our work in community, building trust, in vaccination. And one of the issues that came up that is very interesting is related to what challenges we face in our work as we go by our work. I want this to tie into a very important issue on politicization and political issues. But here specifically, there's a question about the Taliban returning to power in a country like Afghanistan and how that affects polio. Naturally, I'm coming to you severe because Peshawar, Afghanistan, at the border with Pakistan. What do you have to say?
Yeah, so I mean, that's a great point, and I didn't have time to talk about it in 10 minutes, but clearly political issues are a huge piece of this. Of course, also going back to the CIA's fake hepatitis B vaccination campaign in the region to try to find Osama bin Laden. There's all kinds of political dynamics going on. So in terms of the Taliban specifically, the polio program's been working with the Taliban for many decades. And the Taliban often support polio vaccination. Sometimes they don't. It sort of depends on the way that they think it's going to be perceived politically, right? So if they think it's going to be perceived politically to their advantage, they'll support it. So just the fact that the Taliban has taken control isn't necessarily the end of polio campaigns. It's a new challenge that the program is working with. So yeah, I mean, I think that, and the Pakistani Taliban and the Afghani Taliban often have different positions on this. So I think that just highlights the extent to which some of these high-level political advocacy issues are key as well. And that's in some ways a somewhat separate issue from what's going on for individual parents. And these are all things that are happening simultaneously. So I don't know if that answers your question exactly.
Right.
But just to say that the Taliban have a complicated relationship with the polio program, and sometimes they're allies and sometimes they're not.
Right. That's very interesting because also from the other group of questions, generally speaking, I see that the political structures are very important. Either way, whether it's like Taliban coming in or it is the community and how it perceives the political structures in place or context, right? So for this, just to tie into this next question, which I think go to Sarah Cooper, because they specifically asked about it in depoliticizing vaccine campaigns. What would you think, the way I would ask for me the question is, what then would be the role of government in improving community trust, in improving trust, building trust in the vaccine campaign, given that sometimes the political powers in play at the time may not necessarily be trusted by the community? I know one person, Ian Shaw, who gave a good example in Uganda about how they perceive the government on ethnic grounds and those kind of issues, and therefore will also influence the way they take up whichever vaccine comes in. Anyway, Sarah, what do you think? How would you depoliticize, or how can we depoliticize vaccination campaigns? Yet we need to build trust through the same state or government.
Thanks, David. Not a simple question, and definitely not a simple answer. And I think, often in the vaccination world, we want quite neat and easy interventions, but definitely in this side and the politics and distrust of authorities such as government, there's not going to be a quick fix or easy solution that can be uniformly kind of promoted. But I think there are, if we think about COVID specifically, and I think there are things that can be done by governments. So, for example, kind of strong leadership and transparency around kind of decisions and responses to the pandemic more generally, and to vaccines, COVID vaccines more specifically. I think also issues around fair decision-making around COVID vaccine allocations, both internationally and nationally, I think can really restore people's sense that the government has their best interests at heart, it's fair, the decisions they understand and why they're being made. And then I think a big thing that Svea also really raised, I think the kind of standalone programs, I think even if it really generate distrust, and I think even if some of the other political issues we can't restore that faith and that trust, by really integrating vaccination programs within broader health and development programs can go a huge way to restoring kind of people's trust that their interests and their concerns and their needs are being met. I think would be my response.
Right. Yeah, I think so. Not to put you on the spot, but just or maybe any other person may come in. Would you say then that there might be, supposing there are other resources, other structures, whether they are formal or informal, but that can then be tapped into, should the government, like would the government try to utilize, or let me say the partners, Ministry of Health and other actors, try to utilize any other resources that maybe are seen to be more amenable to or close to the community, if it were there? I don't know what you think about that. I'm asking that because one member in the chat asked about a structure like the Rotary groups. That's a structure that I would consider is a formal yet non-governmental, but entails government persons and other important people and does a lot of service. So what do you think? Would that be one way to, I guess, look for certain types of resources, or why have we not yet seen that a lot? It's okay, Sarah, you can go first, or any other. Yeah.
I'll go, and then others can maybe also add there. Absolutely, and thinking of the South African context, I think it's an untapped resource. Civil society organizations, influence of faith and cultural leaders, traditional healers. I think drawing on those resources, involving those kind of groups and stakeholders could go a long way with kind of building the kind of trust and the wider resources. And then I think on a smaller scale, things like, it's quite simple things, embedding social grants initiatives or food distribution initiatives that are kind of going on at the moment in South Africa, incorporating those maybe with the COVID vaccination program, I think could also be a smaller thing that could be done. I don't know if others have other thoughts.
Yeah, I want to hear from Moy, Professor Moy. And I need to hear from you what you think, because you're also in a uniquely placed, given a different set of circumstances that influence uptake, like religion, for instance. I don't know what you think. Yeah.
Yeah, actually, for those vulnerable groups like migrants and all, we actually engage the NGOs who used to work with them, like Mercy and some other Rotary clubs. Actually, they do outreach, and then there is trust with these NGOs, and the chances of them coming forward for vaccination is better than asking them to go to the mega vaccination center where they see some people, some armies and police there, because if they are undocumented, they felt unsafe. So initially, when the government was trying to get this group out, they actually get the NGOs whom they are familiar with to work with them, so that they have confidence in coming out. And for the religion aspect, they get the ustaz to come out with the fatwa, that statement saying that it's legal, it's halal, and assure the Muslim to take the vaccine. So that is not only from the Ministry of Health, but engage the religious people.
Yeah, thank you. One other important question that has come up, Anthony, I'm coming to you, is that we now have Ebola again in Benin, but even more recently, and we're still grappling with Ebola. So one issue is, how do we compare the previous vaccine programs, the uptake, the trust that was built, the challenges faced, to COVID-19? So Ebola, or maybe polio, because we've reported quite some success with uptake, yes, of those and building trust. So the audience is wondering, in your view, what do you think, or how would you compare those two contexts? Is it easier now, harder now? So what do you think, Anthony?
Thank you very much. I think it's two different. I mean, they are very similar contexts, but there are some significant differences between the experiences people had during Ebola and the experiences they are having now in times of COVID. So, as you all know, Sierra Leone have made some significant gains in dealing with or in our response to COVID-19. In as much as communities don't really see like COVID within their community. So most communities haven't seen, say, for example, isolation centers or community members being taken to COVID treatment centers or isolation centers, as compared to how the situation was during Ebola outbreak. During the experiences are totally different. During the Ebola outbreak, you had entire communities being infected and wiping out. You had entire families and loved ones being isolated or quarantined for very long periods of time. So people can see the realness or the actuality of Ebola versus that of COVID. But more importantly, when we started the clinical trials in Sierra Leone for Ebola, there was a lot of emphasis on community engagement, and an entire community engagement team was set up and a social science team set up to understand community dynamics. So a lot of work and effort was put into engaging communities and making sure that people understand what is happening, people understand why the trials are happening, and instill that trust and confidence within the community. Most of that has been lacking in deploying COVID-19 vaccine at every level across Sierra Leone. So I would say, I mean, this is my opinion really, but also kind of informed by some of the work we've been doing. People are more confident about Ebola vaccine than they are about COVID vaccine. So take, for example, in Cambia, where we are doing most of the trials for Ebola, which is a bit different also because Cambia is the only district where the Ebola vaccine trials were happening, and the only district that have some experience and exposure to a clinical trial. So they understand they understand the need for vaccines and things like that. But however, they can still distinguish that I would rather take the Ebola vaccine because I know about it, because I've been engaged with it, because I've spoken to people about it, and I've had so many, I have seen other people take it in my community and nothing happened to them. So I think this doubt about what COVID vaccine could and cannot do at community level and how lacking it has been in engaging communities for them to come up with solutions on what works best for them as a community in terms of deployment strategies for COVID-19, but more importantly also what can help to maximize confidence has quite been lacking. And I think even as I speak, our coverage for COVID vaccine is quite low. So I think those are like some of the thoughts I can bring out here.
Yeah, that's very interesting. May I ask if I asked each of you to just give me two conspiracies that you have encountered in your work, just to name any two conspiracies about COVID-19 hesitancy. then I'll get to the next question as you because it's interesting because of the diversity of where we work.
Maybe I should
NA2.
start.
Yes, NA2, and then
I think one of them is looking at the Sierra Leonean context. During Ebola, there was a lot of resources poured in our healthcare system to respond to Ebola outbreak. So there's this conspiracy that, okay, this is just another way for the government to get more money and just for them to use it. And then I feel like, well, you know, this is just another ploy, another very huge conspiracy between the government and healthcare workers. So that's one key one. Another one is about the notion that these vaccines can actually reduce potency or something. It's part of an idea to reduce the population of Africa, and therefore, why take it if it prevents me from having future babies and things like that. So I think those are some of the most interesting ones I have come across, and common ones we've had most of the time in our work here in Sierra Leone.
Right. Sarah, then I'll come to Foy. Yeah, Moy.
Yeah, so we have quite a few in South Africa. One that was circulating quite a lot is that the vaccine will put a 5G chip into your body. So as you have the vaccine, the chip goes in as a way to monitor the population. And then similar to Anthony, issues around fertility for both men and women, that the vaccine is going to often kind of takes on quite a Western kind of notion that the West has developed these vaccines to also reduce the population control in Africa and reduce fertility.
Right. And Foy, Moy?
Yeah, I think it is quite similar with what Sarah just said. One of it is it will change our gene. So that's why that our people initially, I mean, in our country, there are various types of vaccines. So they preferred, those who felt that certain vaccine will change the gene, they preferred the old-fashioned old-fashioned vaccine that is the from the activated virus. So they preferred that. It's safer. It has been in the market for ages, so they felt safer with that. So yeah, that is one of the conspiracy. Another one is the group fighting for ivermectin. So this group are also against vaccination. So ivermectin is another drug that they thought it could treat, but actually there is no evidence for that. Yeah. So these are the two conspiracies from our side.
Yes, Severe.
Yeah, well, I mean, here in Baltimore, I think the conspiracies in the United States have probably gotten, I don't maybe need to repeat them, they've maybe gotten too much airtime globally. But I will point out that the same concerns, particularly about women and effects of the vaccine on fertility, are seen here in Baltimore as well. So that's a global thread, even though, you know, in the case of Baltimore, the narrative is a little bit different. Obviously, it's not Western countries, but it's, you know, a slightly different set of issues or anxieties around that.
Right. So the thread, as you say, can be quite similar. Sometimes it's macro issues, you know, government, communities, and their relationship to government. You know, it's government making money or something like that. Or it is about, you know, the body. You know, individualized to that level about the body. They're after us, they want to wipe us, they want fertility, some. So that's very interesting, because being able to classify those threads might help, you would think might help in then how to intervene. And so for me, my next question would have been concerning any specific considerations then you can think of that we can, or anything we've learned that we may want to provide to practitioners, for example, to ensure that the rollout of this vaccine is going to be, a lot better, in terms of people understanding and trusting it, since we now think we know or can arrive at some of the major conspiracies, I guess the question is, it's not really a question, but asking commentary on any specific considerations that you can think of. Maybe Anthony, you may want to go first.
Yeah, I think one of the things we found out in one of the surveys we did recently was that people were hesitant because of the side effects that you can get after taking the vaccine. And these are really genuine concerns. It's not like they are like, I am not going to take it, but I'm just worried that if I take it, I'm going to have certain kind of side effects. So I think it is important that people understand, like, that we are honest, first of all, about what the potential risks are and side effects are. And clinicians who actually do the delivery of this vaccination or administer this vaccination should be really upfront about what expectations should be from citizens who take it. And people are very emphatic. I mean, I need to understand what it does to my body. And if I understand that a little bit more, I am more likely to take it. So I think that will be like my comments really on that.
Yeah, which modes of communication, Professor Cooper, would be best to to do this, doing this communicating, and then we'll come to the end of our session.
Yeah.
Very briefly.
Very briefly, I think I agree with Anthony in terms of the honesty. I think there needs to be humility on the part of whoever is giving the information, and a kind of sensitivity that people have very real and genuine concerns. And so to really acknowledge those, and then to be open and honest about what we know, what we don't, evidence gaps, changing in knowledge. So to be humble with that. And then I think in terms of the mode or who, I think it is important to figure out in communities who could be most trusted sources, and to understand that, and then to draw on those resources. So whether it's local faith healers, local leaders, I think people in the community to kind of act as champions could make a big difference with communication, I think. Yeah.
Okay, thank you very much. I think it is clear from the presentations and also the responses and the continuing questions that this is a topic that deserves more than one session, more than 1 hour. And I think it justifies, why we have come together as a coalition and also as a working group. It's been an absolute pleasure to host and to listen to all of you. And so I would like now to request that as our participants, you need to know we have a very short survey. We please request you to fill in that survey. And then lastly, if you're really interested in joining our group, our social science working group, please see the link in the chat, but also there on the screen. We particularly want to welcome people from Asia. We've seen very nice questions, very challenging situations, and Asia and South America, and we need more representation from there. So again, the Asia region, please do not hesitate to apply via our link to join or live in the chat. I now wish to end this webinar here. Once again, thank you very much to our presenters, and we'll be, presenting this on our link, this recording. Thank you very much, and bye-bye.